Hello and welcome to a podcast CME Interview, brought to you by the Royal New Zealand College of Urgent Care. My name is Guy Melrose. Today we're talking about airway management. As with all our podcasts, we try to look at topics that are relevant to urgent care practice and to view them through the lens of an urgent care physician. Whilst we see and treat patients with conditions that affect their airway, we are not airway specialists and rarely have to do the sorts of interventions an emergency physician, intensive care paramedic or anaesthetist might have to. So in this talk with intensive care paramedic Haydn Drake, we discuss approaching and identifying airway and breathing problems in urgent care, in particular those that can progress to a more imminent airway threat, and we talk about how we should be managing them in our clinics. So this is aimed at urgent care clinicians who are not dealing with severe airway and breathing problems on a regular basis, but who might well come across them every now and then. Okay, so there is a reason other than just the alphabet why A is at the start of the ABC mantra, and that is because without an airway, our patients die very quickly, and it's that potential rapid deterioration that I find most scary in an urgent care clinic situation. And whilst we attend yearly ACLS courses, and they do involve managing the airway of an unconscious cardiac arrest scenario, identifying and managing an impending airway problem in an urgent care clinic is tricky and very stressful. So if we have a patient with a severe airway or breathing problem, one of the things I think we'd all agree that we'd be doing is we'd be calling in an expert in out-of-hospital airway management to come to our clinic and help stabilise and then remove that patient. So for today's talk, in order to learn about managing acute airway and breathing problems in a community urgent care setting, I'd like to welcome to the official podcast of the Royal New Zealand College of Urgent Care, Haydn Drake. Haydn is an intensive care paramedic, and he's also a lecturer in paramedicine at AUT in Auckland. He describes himself as an airway enthusiast, and I'm sure he's got a lot to teach us urgent care docs. So welcome, Haydn, and thank you for agreeing to talk to our podcast.
It's a great pleasure. Thank you for having me.
Now, whilst we both work in out-of-hospital settings, paramedics will be seeing a lot more of the severe airway and breathing problems than we get in an urgent care clinic. And so it's that experience of identifying and managing these that I hope to tap into today. We see a lot of patients whose conditions have that potential to deteriorate rapidly in our clinic. And then we also get the odd person who maybe drags himself into the clinic in a state that probably should have warranted an ambulance in the first place. But because it's not a particularly common thing, it does create a lot of heightened anxiety and it raises the stress level. And so I think it's an important topic for us to talk about. And I think if we start maybe with the upper airway problems, how would you approach a patient with an upper airway or a seemingly upper airway problem? How would you approach them and identify these problems?
Well, I think our assessment and approach is going to be very similar to what you guys do in your setting. Clearly going to be looking for respiratory effort and work of breathing, and then with the upper airway looking for any obvious obstruction or swelling. And signs of upper airway obstruction, which would be stridor, which we would auscultate for. When we're approaching any sort of airway problem, we see intubation is the kind of gold standard management, but at the end of the day, what we're looking for is oxygenation, and there's a number of ways we can achieve that without having to kind of go straight to advanced airway cares. There's a lot of the time with airway crisis, we have a patient with appears to have an impending airway problem. There's got a bit of stress and anxiety around that, and that's exactly the same for us. And it's common to have a bit of cognitive overload, I think. these situations, and that can impair our performance and our decision making with that sort of level of stress. There's a great cognitive tool called the Vortex Approach, which somebody may or may not be familiar with already. This was just a cognitive tool put together by an anaesthetist in Melbourne, Nicholas Grimes, and an emergency and retrieval physician, Peter Fritz. And it's just the Vortex Approach is just a funnel, and at the top of the funnel is the green zone where we've got good oxygenation. And when we lose good oxygenation for whatever reason and end up going down the vortex into the funnel, then we work through our different airway adjuncts to try and have a few best attempts at each of those to get back into the green zone. So that starts off with very basic things like bag mask ventilation, or even just mask oxygenation, and then moving on to other adjuncts like laryngeal mask airways and intubation if both of those are unsuccessful.
So that's the Vortex Approach, and we'll maybe put some links in the show notes for people to have a read through that. And I think that's probably an important word to use, approach. If people have an approach to these patients, they're not going to run into a problem. If you jump immediately to thinking that intubation is the answer, in urgent care we're not airway specialists, we're not trained to do intubations. That's the domain of anaesthetists, emergency department physicians, and intensive care paramedics. So we at least don't have that option, which maybe makes us a little bit more anxious because we don't have that to go to. Now, as you mentioned, oxygen obviously is something we can slap on. Posture as well. How do you address the sitting position of somebody with an upper airway? What do you try and encourage them from a postural point of view?
Well, mostly patients will adopt a position anyway that feels best, but having them sitting upright for any sort of airway breathing problem, having them sitting upright helps open up the lungs and their residual capacity, and getting some high flow oxygen going to help maintain that. The oxygenation is really important. Even once they start to, that's right. I was just going to say, even when they become a little bit drowsy and less conscious, tendency is to lie people flat, but that's not so good for their breathing and respiration and airway care. So keeping them upright, even if you're helping them by doing a little bit of a jaw thrust, standing in front of them, is probably ideal.
So until they actually become unconscious and you're thinking of doing some kind of intervention, you would try and keep them sitting upright. But I guess talking to them is calming, and that's probably one of the little things that we can do that makes a big difference, just by standing next to them and talking to them and reassuring them, and whilst things are going on, is important. So certainly if you can spare somebody in your team to be there with the patient at all times and not wandering off, leaving them alone, makes a difference.
Yeah. Absolutely. No matter how stressed we are and anxious we are, they're going to be more so. Yeah, and that's just going to, the more stressed and anxious they are, the worse it's going to make for their breathing and respiratory fit.
Now, the upper airway problems, there's a number of things that could be causing those. Epiglottitis in kids now is very rare, thankfully, with the introduction of vaccinations. Foreign body ingestion is certainly one thing that we might see. Upper airway obstruction relating to anaphylaxis is a possibility. Upper airway infections, sort of neck space infections, and those sorts of problems. Upper airway burns can do it. So there's a number of things that might be going on there. That kind of severe stridor. There are some people who have pre-existing conditions that give them severe stridor, and certainly we do see some nasty cases of croup coming through every now and then. So all of these things might initially, you would do what you've said. You sit them up, reassure them, maybe get some oxygen on. After that, is there any medications that you throw at them in this setting?
Yeah, so we're relatively limited in our field with the interventions and medications that carry. Generally, with any upper airway problem where there's stridor involved, so that would be croup, severe croup in particular. We'd give nebulized adrenaline to help sort of reduce that edema and swelling in the upper airway. And the way we do that, which I'm not sure if the doses will be similar to what you'd use, but we just take 5 milligrams of adrenaline, and we just use the same 1 milligram or 1 mil of 1 in 1,000 ampules that we use for cardiac arrest. So crack open 5 of those, put those into the neb bowl, so we've got 5 milligrams, and we'll just nebulize them with that.
Yeah, I think that's pretty much what we've been told, and it works pretty well. In your experience, does it? Do you often need to go beyond that?
No, very rarely. So it works really well. Most of the time, we're using it as severe croup, and you can see effect quite quickly. Obviously, with croup, it's younger children, so there's sometimes a bit of a fear, and takes a while to get acceptance of the mask. But once they're used to it and accepting of it, then they respond really well. And in those instances, the reassurance comes from keeping them with the parents.
And you mentioned before auscultating for stridor. You can obviously hear it you can hear it with the naked ear, so to speak. But when you're auscultating, how do you approach that sort of upper airway problem? What are you doing from a physical exam point of view when you're assessing?
So you're obviously looking inside the mouth in cases of anaphylaxis. They might have some angioedema and obviously airway swelling, even if it's not around the tongue's lips. It might be the tongue that's swollen and included. And looking for particularly in children, those accessory muscle use around the neck would give an indication to the degree of the respiratory distress. And auscultating, very simple, just using the small bell of the stethoscope and auscultating the side of the neck to listen for not only stridor, but get an idea of how much air is moving. Imagine it'd be very similar to what you'd be doing.
Yeah, it's one of those things that you're sort of taught to do and you see being done, but again, it's that experience of how many times are you seeing that to be then confident in what you're hearing. And I guess sometimes there's that fear that if you hear nothing, is it because there's nothing to hear, or is it because the air isn't moving enough to make a noise? That similar to the silent chest in an asthmatic.
Yeah, absolutely.
So I guess if you're not hearing anything, but the child is, or the adult is visibly posturally in distress, then you it's part of your assessment, isn't it? It's not the diagnosis of it, but you auscultate as part of your assessment and put it all together as a picture.
It's a very subjective thing, auscultation, and then we're obviously pre-hospital working in noisy environments sometimes, so you've got a lot of competing noise and distraction around you. So yeah, it can be a bit hard to judge whether it's just quiet or too noisy to hear, or if there's just nothing at all to hear.
And the inability to swallow, do you come across the drooling patient very often, or because the classic epiglottitis, as I mentioned before, is much more rare than it used to be, but the child sitting forward drooling and
any child that's sort of unable to swallow their own saliva and is drooling like that, it's going to get my own heart rate up, and get me feeling pretty anxious fairly quickly. So that's never a good sign. And I'm always reassured by patients, even if they're feeling like their throat's closing up and have that sensation of their throat closing up if they're able to swallow. That's always reassuring for me.
And you would put nebulized adrenaline on these patients as well, or do you jump to sort of other options like intramuscular adrenaline?
So for anaphylaxis, if it's an allergic reaction and it's angioedema and it's just localized, then our approach would be normally just to go with nebulized adrenaline. And it's we use nebulized adrenaline anytime there's just sort of stridor in the upper airway and swelling. If that angioedema was part of an anaphylactic reaction where they had a systemic severe allergic reaction, then it would be prioritizing the IM adrenaline first and getting that in, and then following that up with the nebulizer. Because we're cracking open five ampules to try and set up that neb, it takes a little bit of time. It's a little bit fiddly. So getting that IM adrenaline in nice and quickly would be a priority for us.
So again, that kind of comes a little bit to the story, doesn't it? Because if your story is one of eating egg and has now got a systemic rash and abdominal pain, wheeze and stridor and angioedema, you're thinking anaphylaxis. But if it's a kid who is playing with granddad's coin collection and is now having difficulty breathing, and you're suspecting this kid has popped a coin in their mouth, the story tells you how you might approach it. So how do you approach the foreign body in an upper airway of a child, say, or even an adult, if that's...
Yeah, and it's a really important thing to bring up, isn't it? Because any child under the age of sort of 5 or 6 that has respiratory, acute respiratory distress, and there's no history of illness or preceding, then foreign body has got to be out there in your kind of differentials and what's going on. Generally, with adults or children, if they've got a foreign body obstruction, but it's mild and they can still move air in and out, okay, and it's going to be distressing for them, but trying to encourage them to cough to clear it themselves is usually the first approach. It's going to be much easier to do that in an adult than it is in a child who's going to be clearly quite anxious and upset and stressed about things. And beyond that, we wouldn't do anything other than sort of transport to hospital with lots of reassurance. If they're still conscious, child or adult, and the ventilation is inadequate, so they're moving very little air at all or nothing, then that's when we'd move to delivering our back blows and chest thrusts. So bend them forward, 5 back blows in between the shoulder blades, nice and firm and hard. And then for the chest thrusts, we're coming in behind them, placing our fist with our thumb in the center of the chest, same as we'd be doing with chest compressions for resuscitation. And then we're just delivering 5 firm chest thrusts, pulling our fist back towards us. And we sort of just check then, see if they've managed to clear it. We'll just keep alternating between the back blows and chest thrusts until the obstruction's either cleared or they then become unconscious. And as soon as they become unconscious, then we move straight on to just resuscitation.
Do you ever make an attempt to remove an object? Is that considered a thing, or?
Generally not. Not if they're conscious. We can have a look with the laryngoscope blade. Just put the tip in a little bit, just to displace the tongue and see if we can have a better look. But generally, if we go delving too far, we're just going to make things worse rather than better. All ambulance staff and I know that Luke Summers has already spoken to you about different sort of practice levels within the ambulance service. So from EMT up through to paramedic and intensive care paramedic all carry the disposable laryngoscope blades and the girl's forceps. So as soon as the patient became unconscious and wasn't responsive, then we could use the laryngoscope blade to get the tongue out of the way and have a good look in the posterior part of the airway and remove any obvious objects with the McGill forceps.
And obviously continue then, once the patient has gone into that cardiac arrest situation, it's the algorithms that we use in ACLS from that point on. Other causes of upper airway problems that we may encounter, inhalational burns might walk in the door because they might not have airway problems at that point. I find some people decide to burn rubbish on their property and might throw a aerosol can into the fire as a fairly common way of, I've come across people doing this, or they get some kind of blowback on a bonfire or something, and they come in with the singed nostril hairs and singed eyebrows and erythema around the nose and mouth. And we've always been taught that's an inhalational burn is an airway problem until it isn't. And so we would usually be calling a paramedic in that situation and arranging the hospital to observe the person for a while. But I guess if an upper airway burn was to worsen, they would be having a lot of the similar symptoms and signs that we've talked about before. Is that correct? Are you just watching for the same deterioration?
Yeah, we're doing exactly the same thing. And these could be quite challenging because you can have that person with those sort of loss of nasal hair or singed lips or nostrils, but they seem fine and they're not showing any signs of symptoms at that point. But it's really hard to judge which way they're going to go if that airway is going to deteriorate and get worse. So it's just good to assume the worst. I think probably from your point of view, with these patients, it's you're obviously going to recognise the potential there, but it's passing that on when you're calling for an ambulance, just to make sure you've got the right skill set that's coming. So with all the different qualification levels that Luke already talked about with you in that previous podcast, if you get an EMT crew turning up, they're unable to manage that airway if it deteriorates. Whereas if you have an ICP, and there's certain intensive care paramedics who have done postgraduate study and have got an extra endorsement to do drug facilitated intubation or RSI. It might be a judgment call and a difficult judgment call, but if there are signs and symptoms of that airway swelling and closing up, judgment to sedate them and intubate them while it's still possible, rather than waiting for the airway to deteriorate to a point where then you're going to be looking at sort of front of neck access for a surgical airway. So get it.
I mentioned before that we're not expected to be intubators in urgent care. There are some people who work in an ED as well, and so will maintain those skills. But it's generally felt that unless you are maintaining skills in intubation, you're not considered an expert, and therefore you should not be attempting to do it. So if we have somebody who we feel might be progressing to requiring that definitive airway and doing it preemptively before the airway completely closes is obviously ideal. We should be calling an ambulance, asking for the highest acuity available, but also asking for an intensive care paramedic specifically when we call the ambulance to enable somebody arriving with your skill set to intervene should it be needed. Is that correct?
Yeah, and what you're probably already aware of is that the ambulance service now has an 0800 line for health professionals to call in. So if you're working in your clinic and you're wanting an ambulance to transport your patient off to hospital or a different centre, then you don't have to call the 111 line, where you just get a non-clinician and a call handler are very, very good at their job, but there to kind of manage lay people calling for an ambulance. With the professional health line, you go through to a clinician, usually it would be a paramedic, and you're able to have that clinical conversation. So you're able to tell them what your immediate concerns are, and it doesn't really matter if you don't know what, if you forget what skill level you need. If you let them know what your concerns are and that's an airway concern, then they should recognise what qualification will be best suited to manage that patient. And it might be that the nearest ambulance crew is a more basic, lower level, but they can get help coming if it's going to be from further away.
Yeah, because sometimes these patients are stable, but they're threatening their airway. And I guess our job should be to identify those sorts of conditions that might be about to deteriorate. And in that setting, if we are aware of the potential, because if we take burns, for example, if somebody was to close over an airway with an inhalational burn, there might be a point at which intubation isn't possible because it's too closed over. So you would want to sedate and intubate that patient earlier. So therefore, having an ICP there earlier rather than later is preferable. But it might be that you arrive and the patient's still sitting and talking, and it's a relatively smooth transfer to hospital. But I guess it's planning for that worst case scenario and being aware and asking for the right team. But if there's no one else available, then an EMT crew to transport that patient to hospital is obviously what's needed.
Yeah, exactly.
When would you
be getting them?
So let's say you arrived at a clinic as an ICP with somebody with an upper airway problem that was deteriorating. You might then decide to do some interventions within the clinic. And what would you want to, in terms of the team around you, what sort of things would you be doing that we should be aware of, and how could we help you or maybe not hinder you in that process?
So in the first instance, it's going to be fairly basic. So these are things that you may have done or will be doing already, but with airway care, having that high flow oxygen on already to try and get that. It's not really proper pre-oxygenation, but if you've got a non-rebreather mask with some high flow oxygen, just building up a better reservoir of oxygen and getting rid of some of that nitrogen is helpful, and it buys you a bit of time if they deteriorate and lose the airway altogether. Positioning is really important, not just from an intubation point of view, but just from airway management in general. So we tend to, paramedics are the same, quite often tend to lie those unconscious patients flat to assist with bag mask ventilation and other airway care. But if they'll tolerate it, having the patient sit or tilted to 25 to 30 degrees, even if they're unconscious, can help with airway management. That just improves the upper airway patency and access. It can help increase that functional residue capacity, can reduce the risk of passive aspiration. It's not going to help if they're actively vomiting. And getting them into that nice position of external auditory meatus to sternal notch, that sniffing position is helpful. And if we're setting up to intubate, those are things that we're going to want to work through and get to kind of maximise our first attempt and try and get first pass success. So if you make a start on some of that side of things, then that's really helpful. If we have an impending airway that we're concerned about, then staying and managing that in your clinic is going to be the easiest thing to do. Once we move the patient into the ambulance, we lose a lot of space. So the stretcher is right up against one side of the ambulance, so we lose that 360 degrees of access. It becomes a lot more cramped and difficult to move in. And certainly when the ambulance is on the go and bouncing around, it's very hard and safe to move around and do interventions. It's very hard and difficult to assess breathing and auscultate. So if there's some immediate concerns, we're going to be much more comfortable. It's going to be a little bit of an alien kind of environment for us. We're not going to be used to your setup, and that's where it might be helpful with just identifying equipment and where everything is, but having that space and those extra pair of hands to assist and fill different roles would be preferable to kind of doing it on our own in the back.
So it's important then, if we call an ambulance for somebody we're worried about, when you arrive, there's going to be a wave of relief come over our shoulders. But it's not a case of saying, right, that's it, I'll carry on and see my next patient, because you guys may hang around to stabilise the patient further. You might not just scoop and run. You might do, depends on the situation, but like you say, you might hang around to decide that this patient needs intubating or needs some further attention. So having a good handover and then hanging around to assist you working in an unfamiliar place and be that extra pair of hands is important. So those of you listening who work in urgent care, hang around when the paramedic arrives to make sure there's nothing that they need until they finally get the patient in the ambulance and whisk them away. I guess the next logical step beyond that intubation, if you can't intubate someone, then a cricothyroidotomy is the next step. We do have kits on our resus trolleys for that eventuality, but I've never had to do one. I hope to never have to do one. It's a reasonably common thing. Well, not reasonably common. It does happen out in the community. It is something that might be necessary. What are your experiences with doing these?
Yeah, so gratefully, I haven't had to do one on a person myself. So I've done airway workshops and done surgical airways on cadavers. It's all about that kind of practice and familiarity for that the rare and essential skills that we need to do. It is certainly something that paramedics do on an occasional basis. So you might have a couple of these a year, and I certainly know of a few paramedics have had to do surgical airways in the community for various reasons, often from an upper airway obstruction. So it can be a challenging thing because taking a scalpel to someone's neck, it's very simple and basic kind of skill to do, but that cognitive hurdle of needing to do it is difficult, and that's where that Vortex approach is kind of helpful as a cognitive tool. So you work through your airway adjuncts. Our backup for not being able to intubate would be to go to laryngeal mask airway and then bag mask ventilation. But if all of those failed, then we'd need to do that front of neck access and surgical. I don't know what commonly you use as far as kits in your clinics and the places that you work. We used to have little cricothyroidotomy kits that we carried, but we've gone to a very simple process now, which is similar to what is recommended by the Difficult Airway Society for those who aren't expert trained in other skills, and that's the scalpel finger bougie technique. So just using a wide blade scalpel for your incision, using just a standard intubating bougie to insert into the cricothyroid membrane once you've made that cut, and then passing a size 6 cuffed intubation tube, or size 5 at least, in to secure the airway. So that's what we would do. Probably different from the kits that you have in your centres.
It's I think some places I've worked have the, as you described, the bougie and the ET tube, and I think those sort of mini cric kits kind of are around as well. But yeah, it's it's an end of the line sort of thing that you'd be doing. You'll have done all of the pre the pre and post arrest airway management adjuncts first, and if you've got an LMA in somebody and they're not moving any air and you think it's because of the upper airway, then I guess that's when you've got to make the decision to do something as seemingly drastic as a crike, because of what else, if they're not moving air with any other technique. And that, I guess, goes to the get the appropriate help early. So if you've got someone with an airway that you're worried about, you want an intensive care paramedic, preferably as soon as possible, because if an intubation is required, then you would rather do it when you can do it than do it when it's tricky or impossible.
Yeah, exactly.
So yeah.
And language comes into it a little bit as part of that cognitive barrier. We often refer to surgical airways as a failed airway intervention or technique. But sometimes, well, a lot of the time, these problems are surgically inevitable. So it's not a case of that we've failed, and that's the only reason we're doing it. It's the clinical condition of the patient and the unfolding condition, whatever it is meaning that it's inevitable. So sometimes getting to it sooner rather than leaving it late is best.
Yes. Yeah, being preemptive, proactive is important. With regards to upper airway problems, there's obviously the most common extension then would be a lower airway problem, and asthma is probably the thing we're going to see the most of. And asthma management, there's a lovely kind of scale up to life-threatening asthma pathways. Our management would be very similar to what you guys do, in that we would be using oxygen-driven nebulized medication, salbutamol, ipratropium, etc. We'd be using potentially intramuscular adrenaline, IV magnesium. I think we've got available in most clinics. When I look through your CPGs, it does mention then that IV adrenaline is sometimes used in severe asthma, and that's something that maybe I've not used personally. You use it in a particular way because it's not like IV adrenaline in an arrest situation. Would you mind talking a little bit about that, the use of IV adrenaline in these sorts of settings?
Yeah, sure. So our approach to sort of mild or moderate asthma would be same as you, and if the patient had a metadose inhaler and spacer, would encourage them to use that in the first instance, or just use the nebulized medications just as you would. If the asthma is severe or immediately life-threatening, then we're going to be going with the IM adrenaline. But we do have that option for IV adrenaline infusion as well, and so that's if the immediately life-threatening asthma, so the sort of peri-arrest, not responding to IM adrenaline. So with our adrenaline infusions, because we carry a very basic number of tools and medications, we just use what's available to us. So we take our 1 milligram and 1 mil, 1 in 1,000 adrenaline ampule, and we'll just add that to our 1,000 mil 0.9% saline bag, and that will make a dilution of 1 in 1 million. And then we just run that through as an infusion. And for a adult, would be running that through at 2 drops per second to begin with, and then we can adjust that carefully, of course, to the patient's condition, depending on whether how they respond to it. For children, we'd do it in a similar way. So between sort of under the age of 14 years and over 5, we would just run it at 1 drop per second, slightly slower rate. and doing it in that nice, controlled manner. There's often a lot of fear and anxiety around IV adrenaline because we're usually doing very large boluses during cardiac arrest. But running it through an infusion like this with that 1 in 1 million, you've got a good control over it, and you can just titrate it gently to what you need as far as the patient's response.
So certainly the likelihood is that in our setting we might have used the IM adrenaline for those severe cases and the IV magnesium. If a intensive care paramedic arrives, you might be starting the IV adrenaline in those severe cases once they've already had the IM adrenaline. This isn't something you would do. You would go through that'd be the tip of the ladder from an intervention point of view, pre-intubation, I guess.
Yeah, absolutely. So generally, we'd always start with IM adrenaline. Unless they looked peri-arrest and but yeah, IV adrenaline is an escalation, and then we would administer magnesium as well for moderate severe asthma, but that IM adrenaline would be a priority, or even the IV adrenaline, if it was indicated, would be a priority over administering magnesium.
So if you guys arrive, then that's something you might do. But people, we mentioned with Luke's talk, the clinical procedures and guidelines book is definitely worth getting or thumbing through a copy if you can get a hold of it, and it outlines a lot of these approaches that you guys go through at each step, and clearly identifies when to move to the next level for any of these things. Because I think with all airway problems, you start simple and you go up through the gears depending on the severity. You've always got to be prepared for the next step. And some cases, you've got to be thinking of the next step whilst giving the appearance to the patient that you're calm and relaxed and you're not worried that they're about to lose their airway. But you've got to be prepared for the next step. And I like the way that your guidelines are very easy to read and logical and go through those steps, because when things are stressful, you tend to lose your focus, and it's better to be thinking ahead and being prepared and trying to keep yourself as calm as possible.
Yeah, absolutely. And those CPGs are great, and if you can't get hold of a physical copy, because it's probably quite difficult for you to do, they do have PDF copies, and in the pocket version, there's nice little single-page flowcharts, which just break things down really nicely. And for the asthma one, that's it all fits on one page, and it just nicely separates into mild, moderate, severe, and immediately life-threatening, and talks you through how to kind of dilute and administer those medications.
And just one final little note before we wrap up. I think it's worth mentioning that I've said before that we have to be thinking of this as what's the worst that could happen with this person. And to be frank, the worst that could happen with an airway problem is fairly rapid cardiac arrest and or death. And so they're obviously serious things. And calling an ambulance because of concern of an airway problem is not the wrong thing to do. If you've got somebody who responds to a nebulized adrenaline such that when a paramedic arrives, the patient is well, you're not going to be thinking, why did they call us? Because had they not responded, then the 5 minutes it took for us to establish that response could have been 5 minutes that makes the difference in the outcome of this person if they were to deteriorate. So I think people in urgent care clinics shouldn't be fearful of involving you guys earlier if you have concern of an upper airway problem, in particular an upper airway or a severe asthma, just because of that rapidity of things going downhill. And I'm sure you'd be happier to arrive to a stable patient that earlier than a sick patient later. Is that correct?
Yeah.
You're not going to grizzle at us for calling you if we have concern of an airway.
Absolutely. Yeah, it's really hard to predict sometimes which way these patients are going to go and how quickly. So getting help there early is much better. And look, you might catch a paramedic who's a little bit late on their lunch for their lunch break, and their blood sugar levels are a little bit low, and a little bit tired or something, and they come across a little bit grumpy. But at the end of the day, much happier to come to patients who are improved and recovered than ones who are deteriorating, getting worse. And the flip side of that too is if you wait a long time or delay calling, and then the patient's sicker when we turn up, then we've got a sicker, more unwell patient to try and manage on the way through the hospital as well, and that can be quite stressful and difficult in the back of a bumping, moving vehicle.
Yeah, so don't fear calling, but also that's where the handover is important. If you are there when the paramedics arrive and can say, hey, this is what this person was like, this was the story, I was worried, thankfully they've improved a bit, but hey, I'm glad you're here. That goes a long way to making sure that the interface between us is smooth and respectful. So yeah, hang around. If you've called an ambulance, hang around, hand over, and we can learn watching you guys do your bits as well. Because like I say, the IV adrenaline, the intubations, the extra things that you bring, we can learn from you as well by hanging around.
Well, yeah, we really appreciate having that handover from the clinician who's been looking after the patient, because we've just walked into the room, and it's going to take us a little bit of time to kind of orientate to what's been happening with the patient. We might not appreciate the work that's been done before we get there, and how bad the patient looked initially. So having that clinician who's been there with the patient and looking after them, able to give that handover rather than sort of getting it secondhand through nurse or someone who's just come on shift, is really helpful.
Yep. And one final thing, we've mentioned Luke a couple of times here, that our chat with Luke, he mentioned during that talk, his phrase was, paramedic registration is inevitable. And since we talked, that inevitability has come to fruition, hasn't it? It was announced that from the 1st of January next year, paramedic registration as registered health practitioners is now all go, isn't it? So congratulations to you guys. You've worked very hard to get that.
Yeah, it was a little bit of a surprise. It came a little bit quicker than what we thought, but it's great news. So a lot of work still to do next year was setting up the paramedic council and all the other structures that you're already all familiar with that will be new to us. So it'll be good.
So it's the beginning of a new era of paramedicine in New Zealand. And as Luke said, it's going to lead to other developments as well going forward, and the role of paramedicine is certainly within the community as well will change, or be not change, it'll be added to. There'll be additional roles and things. So it's an exciting time for you guys. So yeah, it was when Luke said inevitable, it was a little quicker than you maybe thought, but that was great news to see. So thank you, Haydn, for going through that. It's having you guys arrive, as I say, is a huge relief when an ambulance rocks up with a patient we're concerned about. And it's nice to hear that you guys are also a little bit anxious when dealing with these, because it certainly adds to our anxiety levels. But just having that structured approach, and I think my take home from here is that structured approach, constant reassurance of the patient, constant monitoring of the patient, and not being afraid to call for help sooner rather than later is certainly what I'm going to make sure I try and take into my practice. So I appreciate your talking to the podcast today.
Thank you very much for having me.
So if I was to summarise what I took from our chat, it would be this. Dealing with airway problems can be stressful, and they lead to a lot of cognitive overload. Having a measured approach to dealing with these cases helps provide a framework by which to tackle the problem. I have linked in the show notes to the Vortex Approach that Haydn mentioned, and it is worth watching the video and reviewing their website. I will make sure that I remember to address the simple things first, such as positioning the patient and reassuring the patient. We must not let our minds jump too far ahead, thinking that intubation or cricothyroidotomies are needed. The Vortex approach again helps with this, but also it is worth reading a case that highlights this, and a whole host of other key points relating to managing a severe asthmatic. And it is a case that was presented in one long Twitter thread by Dr. Sam Ghali. I have retweeted this thread and would encourage you to read through it all, as he discusses managing a severe asthmatic without intubation. If you're not on Twitter, go to the college website and click on the little bird icon in the top left, and it will take you to our page where you'll be able to read the case. I'll also make sure that in calling for an ambulance in a patient for whom I have airway concerns, that I request an intensive care paramedic if available. If I'm not calling the ambulance myself, I will make sure the person who is aware of this request. And when the ambulance arrives, I'll make sure to hand over and remain with them until they leave the clinic. And I will not allow myself to fear calling for help, both within the clinic or from an ambulance, in anyone for whom the airway is a concern. As Haydn says, an intensive care paramedic will be happy to arrive and find an improving patient on an adrenaline neb, but if this patient had gone south, getting expert help there sooner is better for all involved. So if you're worried, call for help early. Now, I've also linked in the show notes to the CPGs from the St John ambulance here in New Zealand. The pocket version is excellent, and I would recommend you have one printed in your resus rooms or available on your desktops. It's also a good idea to review the equipment in your resus so you're familiar with where everything is, and running through rare use items such as the emergency cric kit is something that is worth doing every few months in the hope that you'll never have to use it. So my thanks to Haydn for talking to our podcast. In a future podcast, we will be talking with Haydn again about managing stress and cognitive overload in stressful emergent situations. If you have any comments, questions, corrections or suggestions, email podcast@rnzcuc.org.nz. We'll be back next week with another podcast. I look forward to seeing you all then, but for now, thanks for listening. The information discussed in this podcast was intended for the ongoing professional development of qualified health professionals and should not be used for self-diagnosis. For any personal medical concerns, please consult your usual doctor.